Association of lumbar paraspinal fascia with low back pain and disability. Myofascial pain has been a focus for chiropractors and manual therapists for decades. The implications of involvement extend across a wide variety of theories and resulting manifestations of pain syndromes based often on a specific component of myofascial structure. Confusing terminology from different camps of thought make discussion and research findings difficult to discuss and compare. However, trigger points, myofascial adhesions, and compartment syndromes are some of the more common categories investigated. The current publication we will discuss is a focus on one of these categories, compartment syndrome, not often associated with the spine. The title is Shorter lumbar paraspinal fascia is associated with high-intensity low back pain and disability, published in Spine in 2016. Before we discuss this specific study, let's review broadly the spinal fascial structures and how they're organized and discussed functionally. Divided into three layers, the fascia of the back is complex, comprised of aponeuroses, aponeurotic fascia, and epimysial fascia. An aponeuroses is like a flattened tendon, whereas aponeurotic fascia and epimysial fascia are associated directly with the underlying muscle. The aponeurotic fascia is thick and distinct, whereas the epimysial fascia is thin and adherent. This combination of epimysial and aponeurotic fascia allows the transfer of forces along myofascial planes. Researchers and more often biomechanists and therapists refer to this type of fascial arrangement as either meridians or slings. This is in reference to the extensions of fascia across joints and often regions to create supporting and stabilizing structures that are able to distribute loads across greater areas. Specifically, the thoracolumbar fascia is most important to our discussion. Most individuals refer to it as a two-layer structure with the anterior layer as part of the deep layer of the deep fascia of the trunk. The posterior layer of the thoracolumbar fascia is superficial, connecting the latissimus dorsi on one side to the gluteus maximus of the other side through the erector spinae aponeuroses, often referred to as the posterior oblique sling. As Stecco describes, the posterior layer of the TLF represents a large retinaculum that connects the two halves of the body, upper limb on one side to the lower limb on the other, allowing proper distribution of forces during, for example, the pendulum action of the arm and contralateral leg with walking and running. Most manual therapy treatment approaches have focused on the sling system through stretching, exercise, myofascial release, etc. On a more segmental level, the thoracolumbar fascia is also known to contribute to lumbar stability, working synergistically with the deep muscles and ligaments of each spinal segment. These fascial compartments will be a focus of our discussion. Dysfunction or damage to the fascia has been associated with back pain or back and leg pain. Studies have focused on the following main areas: determining the sensitivity of the thoracolumbar fascia, determining if entrapment of nerves in the fascia could be the source of some back or back and leg pain, and determining if increased pressure inside fascial compartments could be a source of pain. Here's a study investigating the sensitivity of the TLF entitled Sensory Findings After Stimulation of the Thoracolumbar Fascia with Hypertonic Saline Suggest Its Contribution to Low Back Pain, published in Pain in 2014. They conclude the thoracolumbar fascia is the deep tissue of the back that is most sensitive to chemical stimulation, making it a prime candidate to contribute to nonspecific low back pain. And another publication investigated what many refer to as Main syndrome, where the lateral branch of the posterior primary rami supplying the skin over the low back and gluteal region is entrapped in a fascial tunnel. It's entitled Prospective Study of Superior Cluneal Nerve Disorder as a Potential Cause of Low Back and Leg Symptoms, published in Orthopedic Surgical Research in 2014. In this study, after 3 injections, 85% of patients experienced more than a 20 millimeter decrease in the VAS, and 68% of patients experienced more than a 50% decrease in their VAS scores. Numerous studies have hypothesized that low back pain may be the result of a compartment syndrome, specifically in the paraspinal fascial compartment. Pressure in the compartment increases, leading to ischemic muscle pain. And increases in experimentally induced pressure returns to normal when the fascia is cut, called a fasciotomy. So what constitutes the fascial compartment? Well, the erector spinae fascia has separate fascial compartments only for the interspinalis and multifidi, while the other erector spinae muscles together have a fused compartment. Most MRI studies of fascia have used a qualitative grading system. They use terms such as flat, convex, or sagging. Sagging lumbar fascia was associated with adjacent lumbar segment disease, and a flattened lumbar fascia was associated with lumbar degenerative kyphosis. Yet, although fascial layers have been investigated, the fascial compartment, determined by fascial length and cross-sectional area, has not. More on that later. So now on to the current study. 72 individuals were recruited through local media and weight loss clinics as part of a study of obesity and musculoskeletal health. Participants were not required to have low back pain or a history of low back pain for inclusion in the study. So who were the patients? Well, primarily women with an average age of 48 years and a BMI of 29. High-intensity low back pain and disability was reported in about 20% of participants. The mean fascial length was 12.9 centimeters bilaterally, and the mean cross-sectional area of the right and left paraspinal compartments was around 25 centimeters squared. So how were pain and disability measured? The Chronic Pain Grade Questionnaire was utilized at the time of the MRI to obtain information on low back pain intensity and disability over the past 6 months. 7 questions are used to provide a grade from 0 to 4. Grades 2, 3, and 4 were considered to represent those with high-intensity pain and/or disability and were combined for analysis. Unlike prior studies which focused on the fascial layers and their thickness, quantitative measures using MRI in this study focused on 2 aspects, fascial length and cross-sectional area. In that way, shortened fascia could be compared to decreases in the cross-sectional area. Fascial length was measured from the tip of the transverse process to the tip of the spinous process. The cross-sectional area of the compartment was measured by tracing the full perimeter of the compartment on the MRI images. So the results? It showed a trend for a shorter fascial length to be associated with an increased risk of high-intensity low back pain and/or disability. In multivariable analysis, adjusting for age, gender, and BMI, the relationship between fascial length and high-intensity low back pain and/or disability was significant. When the association between the fascial length and high-intensity pain and disability at each lumbar level was examined, results were statistically significant except at L5. There was a strong association between compartment cross-sectional area and average fascial length. The exception at L5 was explained by the researchers as likely a problem with measurement with regard to the transverse process and iliac crest. In this article, published in 2012 entitled Lumbar Paraspinal Compartment Syndrome, a literature review was performed. They found only a few cases of paraspinal compartment syndrome in the literature, which could be divided into acute versus chronic. The acute type was due to either direct trauma, surgery, or from skiing, surfing, or weightlifting. For the acute type, there was loss of sensation over the area, and there were lab findings of elevated creatinine phosphokinase, SGOT, and serum and urine myoglobin. Compartmental pressure increases were consistently seen. For the chronic exertional cases, there was no trauma, pain was exertionally provoked, and there was no pain at rest. Extension relieved the pain, and flexion worsened it. Here also there were compartmental pressure increases, however, normal lab values. The outcome for many patients was fasciotomy to relieve the compartment pressure. This was successful in most cases of chronic exertional compartment syndrome and should be considered an option failing other conservative approaches. So, how would we put this information to use? It appears that paraspinal compartment syndrome is real, given that fasciotomy is curative in many cases. What we don't know is whether myofascial approaches directed specifically at these compartments could be successful. So, are we dealing with two different conditions? Are myofascial sling disorders more broadly causing low back pain and other associated problems, or is the patient suffering from a low back compartment syndrome? From what we have discussed, the only objective evaluation approaches are measurement of fascial length and compartment area on MRI, or measurement of compartment pressure. For the average practitioner, both are unlikely routinely available, so approaches using targeted myofascial work will be hit or miss until more studies comparing results to clinical presentations and findings are conducted. It would appear that if myofascial therapy is not being applied to a specific low back pain patient, and they're not improving, that a trial with a focus on this area is warranted. Definitive diagnosis is problematic. However, in recalcitrant cases, measurement of compartmental pressure coupled with either diagnostic ultrasound evaluation and MRI might be warranted. As usual, case series publications would stimulate interest in more extensive, well-designed interventional studies.